So after a nice coffee break, we are back. So I will be talking about viral hepatitis, its differential diagnosis, and how the journey from acute viral hepatitis to ALF goes on. So outline would include clinical presentation and definition of viral hepatitis, causes of viral hepatitis, its differential diagnosis, then journey from AVH to ALF. Then I will be talking in brief about certain ALF definitions, and then concluding slide. So first and foremost question is why we should bother to learn about viral hepatitis. Why to take so much of pain? So the answer to this question lies in the high amount of mortality which is because of liver cirrhosis as well as acute hepatitis. So you can see because of these etiologies there is a huge mortality which is seen in the population. Hence, if we can prevent or actually treat patients in time, we can prevent mortality as well as morbidity. So hence the need to learn about viral hepatitis, prevention and timely treatment. So coming to the clinical presentation of viral hepatitis. So viral hepatitis can be divided into two. One is the acute hepatitis, second is the chronic hepatitis. So acute hepatitis broadly is caused by viral hepatitis A, E, and sometimes hepatitis B, whereas the chronic hepatitis, as you know, is caused by B, C, and hepatitis D. So when patient develops acute viral hepatitis, he can progress to acute liver failure, which I will be talking in subsequent slides. And when the patient develops chronic viral hepatitis, he can progress to liver cirrhosis, which in turn may lead to portal hypertension and symptoms, and in turn development of hepatocellular carcinoma. So now coming to the definition of acute viral hepatitis. So acute viral hepatitis can be defined as an acute illness which is characterized by the acute onset jaundice associated with dark colored urine, with anorexia, malaise, fatigue, etc., right upper quadrant discomfort, raised urine bilirubin, and serum ALT more than 2.5 times of upper limit of normal. So these are the different phases of illness which are usually seen in acute hepatitis, which is mostly true for all the viral hepatitic illness. So first stage is the stage of prodrome. So all of us are familiar with the prodrome term, which includes symptoms like malaise, fatigue, low-grade fever, nausea, vomiting, aversion to food, mild itching, joint pain, which usually lasts for a few weeks, a few days to a few weeks. Then comes the icteric phase, which is the symptom in which usually the patient presents with yellow colored eyes, dark urine, light colors too may also be seen sometimes. And in this phase, usually the prodromal symptoms gradually subside, and this usually lasts for up to 6 weeks it can last. And third, if the patient recovers, and it is called the convalescence phase, where gradual recovery is the rule. So what does the global data of acute viral hepatitis say? According to the global data, hepatitis A virus is the most common cause of viral hepatitis illness, followed by hepatitis B, E, and C. But this is the global data. When it comes to India, hepatitis A followed by hepatitis E rule the roost, and they are the most common cause of viral hepatitis. So now, what is this term called hepatotropic viruses? I know all of you must be familiar with this term, but let's recapitulate. So viruses that selectively and preferentially target and infect, causing injury to the liver cells, are called hepatotropic viruses. So all of us know that these are hepatitis A, B, C, D, and E. These are the primarily hepatotropic viruses which cause the acute or chronic hepatitis. So now coming to the route of spread of these, so we know that hepatitis A and E is primarily caused by fecal-oral route, whereas B, C, and D are caused by parenteral route, which we know either could be because of unsafe sexual practices or blood transfusion or mother-to-child transfusion. And acute presentation is primarily seen in hepatitis A and E, and primarily B and C will cause chronic illness. However, hepatitis B may sometimes cause acute illness also. A point to remember is that hepatitis E may sometimes cause chronic infection, which is usually not seen in immunocompetent individuals, but in those who are immunosuppressed, for example, those who have malignancy or those who are on immunosuppression like post-liver transplant or for chronic immunoinflammatory disease like those associated with rheumatology. So those patients can develop chronic hepatitis E. So we know this is a very basic slide, but still we should cover it. That what are the tests for hepatotropic viruses which we do? IgM anti-HAV, IgM anti-HEV for hepatitis B, we do HPSAG, and IgM for anti-core antibody, which is the IgM anti-HBC. And for anti-HCV, we do anti-HCV antibody and antibody testing for hepatitis D virus. So now, after suppose the patient has presented to you with findings suggestive of acute viral hepatitis, you run the panel for viral hepatitis A2 and they come out to be negative. Then do we say that the patient doesn't have acute viral hepatitis and we look for some alternate diagnosis? No, the answer is no, a no, big no, because there are non-hepatotropic viruses also which can cause acute hepatitic illness. And the most common causes include herpes simplex virus, varicella zoster, Epstein-Barr virus, cytomegalovirus, dengue virus, coronavirus, and adenovirus. There are other non-hepatotropic viruses also. Primarily, these are the major non-hepatotropic viruses which you should rule out after you have done a battery of A to E test. So A to E negative, then you should do this second degree of test to rule out these non-hepatotropic viruses causing viral hepatitis. So now the question comes, when to suspect non-hepatotropic viruses as cause of acute viral hepatitis? This is a very pertinent and important question. So the answer to this question is that if the serology for hepatotropic viruses are non-reactive, if patient is immunosuppressed, like patient with HIV or organ transplant recipient, those who are receiving immunosuppression, or those patients who are having prolonged course of illness, like they are not taking too much time to recovery, or the viral syndrome, which is the prodromal syndrome, is less marked. So then also we should suspect atypical viral illness. Then comes level of elevation of liver enzymes. So in acute viral hepatitis, usually those which is caused by the hepatotropic viruses, in those the enzyme elevation usually runs into 1000. So if in a patient OTPT are elevated, but let's say it is 3 to 4 times elevated, and bilirubin is also 4, 5, then you should also suspect non-hepatotropic viruses as cause of illness. And if patient is having any uncontrolled systemic illness, and if patient has recently recovered from any life-threatening infection or sepsis, then these are the conditions where you should suspect non-hepatotropic virus. So now coming to the differential diagnosis of acute hepatitic illness. So if a patient presents to you with jaundice, prodrome, fever, so what all differential diagnosis you should keep in mind? The first and foremost diagnosis in our country is tropical infection. You know, this is the season of dengue, malaria. So if any patient who presents with acute hepatitic illness, we have to rule out malaria, dengue, scrub typhus, leptospirosis, chikungunya, and typhoid. So differentiation with these diseases must. And how you can differentiate clinically? Suppose a patient has fever, prodrome, and then he develops jaundice. And even after development of jaundice, his fever doesn't subside. This is a subtle marker, and this may be because of tropical infection. Because in usually viral hepatitis, when the jaundice sets in, the fever subsides. So this is an important clinical marker which you can keep in mind, that if fever is persisting despite development of jaundice, then you should keep the possibility of tropical infections in mind. Then second, you can look at this general physical examination. If there is conjunctival suffusion, hepatosplenomegaly, then you can think of malaria and hepatitis. And for scrub typhus, if eschar is present. For leptospirosis, if patient has gone outside and has had drenched himself in rainy water and all, then you can suspect these illnesses. So clinical correlation along with meticulous history is important while making a diagnosis and ruling out the other differentials in case of acute viral hepatitis. Second is the other infections like amoebic and pyogenic liver abscess. Patient with amoebic or pyogenic liver may also have fever, jaundice, as well as prodromal symptom. But here he will be having tenderness in his right upper quadrant, and when you will subsequently do imaging, you will find the evidence of liver abscess. Then comes hepatobiliary tuberculosis. So in case patient has hepatobiliary tuberculosis, he can also have acute hepatitic-like presentation, but he will be having other features like anorexia, weight loss, raised ESR, MEN2 test positive, some evidence of extrahepatic involvement like pleural effusion or lung involvement or lymph node on general physical examination. Whereas in sepsis syndrome, if a patient has sepsis because of any cause, he can develop sepsis-related hepatitis, which can also mimic the findings of acute hepatitis. So the first is tropical infection, second one is the other systemic infection and local infection of the liver. The third is the autoimmune hepatitis. So autoimmune hepatitis may also present with fever like low-grade fever, prodrome, as well as jaundice. But here you will need to ask the patient whether the patient has other features of autoimmunity, whether there is any family history, especially in females, like history of thyroid disorder, diabetes mellitus, vitiligo, or other joint disease. If such history is there, then you will need to do the autoimmune markers, and if autoimmune markers come out to positive, then you will eventually have to differentiate between acute viral hepatitis and autoimmune hepatitis based on the finding of liver biopsy. Because just on the basis of serological markers, it becomes very difficult, because autoimmune markers are positive even in at least 20 to 25% of general population. So once, if you suspect autoimmune hepatitis, then liver biopsy is a must. Then comes the important differential Wilson disease. Wilson disease in its acute presentation can also present with acute hepatic-like illness. But here you will have findings like patient may have KF ring on slit lamp examination. He may have neuropsychological manifestations. And patient may have evidence of hemolytic anemia, which is non-Coombs positive. So if Coombs test is done, it is negative, whereas the patient is having picture of hemolytic anemia with unconjugated hyperbilirubinemia. Then these findings favor Wilson disease. So then comes another important cause, which is drug-induced hepatitis, which is increasing day by day because of the use of complementary medicine, which is promoted by various departments of the government as well as non-government organizations. So drug-induced hepatitis has to be ruled out in patients with acute hepatitis. You have to ask the patient whether you are taking any Ayurvedic medication, you are taking any jadi booty. You can specifically ask whether you are taking any Pathology product, liver 52. All these drugs are known to cause drug-induced hepatitis. So you have to specifically ask. And then one important thing you have to ask in young individuals is whether you are taking any protein supplement, those who go to gym and do heavy workout, because these protein supplements are known to contain contaminants that cause hepatitic illness. So these things have to be specifically asked in history. So last, you have to rule out any poisoning like yellow phosphorus poisoning or any pesticide poisoning. These can also present with acute hepatitic illness. So this you can only know once you have taken a meticulous history and done a physical examination. So this is the broad differential diagnosis of acute hepatitis, which you have to rule out, particularly in our country. So now coming to the journey from acute viral hepatitis to ALF. So by now we know that acute viral hepatitis presents with acute onset jaundice, followed by dark urine, anorexia, malaise, all the features of prodrome, followed by raised urine bilirubin and AST levels more than 2.5. So if the patient is not treated properly at this stage and he progresses, what will be the next stage? So next stage will be the development of coagulopathy. So coagulopathy can be defined if INR becomes more than 1.5, along with the features of acute viral hepatitis. Then the patient will develop acute liver injury. The patient will progress from acute viral hepatitis to acute liver injury if he develops coagulopathy along with acute viral hepatitis. And what will be the next step? Next step will be the development of acute liver failure, which is a very life-threatening condition. So along with the features of acute liver injury, if patient develops any grade of hepatic encephalopathy, the point is any grade, even if grade 1 of hepatic encephalopathy is present in a patient with features of acute viral hepatitis and coagulopathy, then we have to characterize this patient as acute liver failure, and this patient requires immediate ICU admission and very meticulous treatment, and may also require liver transplant if he or she doesn't improve on conservative management. So hence this spectrum has to be kept in your mind, that you do not diagnose and treat patient of acute viral hepatitis coagulopathy. He or she will progress to acute liver injury, and from acute liver injury, we never know, he or she may progress to acute liver failure. So this is the flowchart which you must keep in your mind, whether your patient is having acute viral hepatitis, acute liver injury, or acute liver failure. So now There are various definitions which are available. You must have read in your textbook or any review article. Like there are definitions by O'Grady, Trey and Davidson, by Indian Association of Study of Liver also, and Japanese definition. But the definition which personally I would recommend you to remember is the ASLD definition, which says that any patient with jaundice followed by encephalopathy within 26 weeks associated with coagulopathy with INR more than 1.5 and any grade of hepatic encephalopathy will classify as a case of acute liver failure. So if you do not want to get confused and want to remember single definition, it's better to remember the ASLD one. Although it is up to you, if you are comfortable with any other definition, it's up to you, but I would personally recommend this ASLD definition. ASLD stands for American Association for Study of Liver Disease. So now I would like to give you a brief concept about acute liver failure and acute and chronic liver failure. You must have heard our term of acute and chronic liver failure. So before understanding this concept, I would like to tell that there are two types of liver. One is the liver which is perfectly normal and another is the diseased liver. So if the patient's native liver is normal and he suffers any acute insult like acute viral hepatitis, then he may progress to acute liver injury. And gradually, if he develops hepatic encephalopathy, he will develop acute liver failure. Whereas any patient, because of any reason, chronic hepatitis or alcoholic liver disease or NASH, has a diseased liver, like he has high fibrosis, F2, F3, which were discussed by Rungta sir previously. So in that liver, if a patient develops acute insult, and along with that, patient develops ascites or encephalopathy, he will be having acute or chronic liver failure because his native liver is not normal. So for a patient to develop acute liver failure, his native liver should be normal. If the native liver is not normal, he will develop acute or chronic liver failure. So these two things you should keep in mind. So to conclude, there are 5 hepatotropic viruses which are well characterized. Hepatitis A and E cause acute hepatitis, which in turn can progress to acute liver injury and then to acute liver failure. Hepatitis B, C, D cause chronic infection, which in turn can progress to cirrhosis and to hepatocellular carcinoma. Non-hepatotropic viral hepatitis is commonly seen among immunocompromised patients, and you should also keep a differential of non-hepatotropic viruses causing viral hepatitis in such patients. And finally, tropical infection causing acute febrile illness has to be a close differential diagnosis of acute viral hepatitis, especially in our country. Thank you.